am a geriatric nurse practitioner. One of my specialties is continence care, particularly in elders and in long-term care. I work for Presbyterian Homes in the Chicago area, and there I am the Director of Quality. So welcome to everybody. To me, this is an area, as I've been sitting here over the last 2 days, and I hear all the huge breakthroughs that the greenhouse model has made in terms of the way that we care for elders and give them life. I say to myself, maybe this is the arena where a breakthrough in continence care actually has the potential to happen. So we only have a small group here today, but boy, let's plant some seeds, let's warm that ground, and let's get moving. Actually, 6 out of 10 elders that move into long-term care come in underwear. 10 days later, 6 of those people will be incontinent and wearing products. So the place we need to open at is really busting through some myths that we have about aging and continence. So I'd like to invite you all to stand, all of you. And this is what we're going to do. I'm going to give you a question, and it's a myth question. And if the answer is yes, this is true, I want you to move to that side of the room. If the question is no, that's very false, I want you to come to this side of the room. And I want you to kind of, it's like a Likert scale. If you're a 2, if you're a 3, you're not quite sure, you can position yourself anywhere along the continuum. All right. So this is question number 1. Urinary incontinence is primarily the result of aging. Is that true or is that false? Whoa, look at these very smart people. Question number 2. 75% of nursing home residents are incontinent. Is that true? Is that false? Valerie, give me a statement about why you're in the middle. Okay, and I should do the microphone when I ask people to speak. I think what you're saying is sometimes people get labeled incontinent and put into products, and the reality is that they're not really incontinent if we could evolve a different system of care. You're absolutely right. Women are affected twice as much as men. True? False? Ooh, you're right. Okay. More than half of incontinent persons may experience a decrease in the number of urinary incontinent episodes using behavioral interventions. Oh yes, look at that group not move. Okay. Using bedpans to assist people in being continent at night is a good idea. Little bit more divided? What are you thinking?
I think that bedpans don't allow you to totally empty, but if it's for the comfort of the person, then if that's what they desire, then it's okay.
Oh, you are so right. Anybody here been in the hospital and had to use a bedpan? Yes. Oh my. Did you empty well? Oh no. And it doesn't help as you get older either. Residents on dementia units are good candidates for urinary incontinence management interventions. True? False. People on dementia units are good candidates. Janet, you're very pensive there. Not sure.
It depends. I guess if you get them into a routine,
okay,
and it's the same structured routine all the time, then yes, maybe they would be.
Okay, so there might be things we could do. Last question. The chief confounding factor for incontinence appears to be impaired mobility. True or false? Oh, Stephanie, I'm coming to see you.
I think sometimes it's with the immobility, but sometimes it's people don't want to. I've got elders that do not want to get up and go to the bathroom. They got to have encouragement, even though they've got the ability to mobilize.
Okay, so you do have people who can mobilize but don't want to go. So there's a component of this, and it's come through real strong as I've read the questions. This is a person-centered arena. This is not a one-size-fits-all, and this is not something that we are going to solve without a lot of work and individualized type care. Okay, you can all sit down again. No, not quite. Okay. This is not rocket science, right? What you guys do every day, 100% harder than rocket science. Because we do work with myths, we do work with science, we do work with art, we do work with all these very... So as you go back to your seat, please give one of your colleagues a high five and thank them for the good job they do. Have any of you ever worn a product in here? Anybody worn an incontinence product? You know, when Anna Ortegara teaches the LEAP program, the first thing she does when you walk in the door is she hands everybody a big old brief and an empty glass, and she sends them off to the bathroom. And she says, come back wearing the brief, and while you're in the bathroom, pour a glass of water into the brief. Make the water warm, because if it's cold, you'll give yourself a little shock. So I have done this for years and years and years and years. Got any ideas what people say when they come back in the room and you make them sit through the presentation in a brief? Uncomfortable, cold, ew. I want to ask the gentleman in the room, because men usually have a real problem with this. How do you think you'd feel if you were wearing a wet brief? Would not like it. How do you think you'd be sitting, folks? How do you think you'd be sitting in your chair? It is amazing to watch this. You'd be fidgeting. Some people stand, agitated. They stand because they're afraid they're gonna leak. Okay? They slouch. These are words they use. It's sticky. I walk differently. It makes noise. It's embarrassing. It's squishy, uncomfortable, gross. My clothes fit differently. Now, I couldn't do that today because I didn't warn you to wear loose clothes. I don't usually tell people what I'm going to do. I just say, please dress in comfortable, loose clothes. So we won't do that today. But I would certainly encourage you to do it. Now, the next question I want to ask you is, what kind of products are you using where you work? Tana? Great product. Are you using briefs? Are you using pads? Are you using mesh pants? Briefs, pull-ups? Tana pull-ups and briefs? Briefs? The panty, you have a real panty with a pad in? No pad. Your people are all wearing real underwear.
I take panty liner. It's make me uncomfortable, kind of like something rushes. I got rashes.
Okay.
Maybe I'm allergic to the reaction. I don't know.
Okay. Okay. All right. So this is what we're going to talk about. We're going to talk about normal bladder function. We're going to talk about how normal aging affects the bladder, and we're going to talk about bladder problems and some solutions. Everyone needs to remember it should never be assumed that bladder problems are inevitable or untreatable. This is almost untenable to a lot of people to think that we could get elders back in real underwear. There are effective treatments for bladder problems. We're going to talk about a lot of simple things we can do here. And please remember, complete control to move from profound wetness to near dryness, or from total dryness during the day to some wetness at night, is a huge progression. So we can treat things. Does that mean everybody's going to be totally dry? No. But we will talk about that. 3 essentials that promote normal bowel and bladder function. 1, mobility. If you can't get to the bathroom, or if it's not easy to get you to the bathroom, are there any Shabazz in here? Yes. If somebody can get up and walk, is it more likely that you're going to be able to take them to the bathroom than if they need a lift?
I have one lady, if she's wet, you never let her down because she is comfortable. She tries to fight. But if you cut ahead of time that she's already go to the bathroom, she will.
Can she walk to the bathroom?
Yes.
Yes. With a walker. Okay, so she can get there with some assistance. We have a real need to keep our people mobile, because once people go into the place where they need the Medi stand or they need some kind of lift, or if they're very heavy, the chance that people are regularly going to be able to get them to the toilet on time goes down. Second thing is hydration, and we're going to talk a lot about the role of fluids. Because what people tend to do as they age and they start having accidents, what do they do with their fluids? They decrease them. This is not a good idea. And the third thing is bowel hygiene. There is a real connection between bowel function and bladder function. And so we have to become aware of that and know that constipation is the worst enemy of continence. So what's necessary for bladder control? For bladder control, you need a bladder, number 1, that can hold urine. So I love to do this with a balloon. This is my bladder. This is my urethra leading to the outside, okay? You need a bladder that can hold urine. This is my sphincter. You need a urethra that can open and close. There's a sphincter at the base of the bladder, and there's another sphincter at the opening. The sphincters are normally closed. We voluntarily open them, and we have to be able to do this to have continence. When you have a prostate problem, the problem in the prostate is that the prostate is right where this sphincter is. The prostate grows. It closes off the opening to the bladder, and the ability to open and close becomes compromised. So we need a bladder that can fill. We need a urethra that can transport the urine to the outside. We need an intact spinal cord. The reason the nerves there's sensors in the walls of the bladder that tell you how full is your bladder. those sensors send signals to the spinal cord. The spinal cord transmits those impulses to the brain. The brain goes, it's full, it's full, it's full. But you know what? I'm sitting in this session on continence right now and I can't go to the bathroom. So, from the frontal lobe of your brain, you send a signal back to your bladder and you say, well, I'm sorry, bladder, but just relax for a little while because you can't go to the bathroom right now. That's why sometimes if you're driving in the car, you can put off the impulse. On the other hand, if you can go to the bathroom at that point, what happens is you transport yourself to the bathroom, a bladder contraction takes place. The bladder is basically a muscle. So the bladder contracts down at that point. You open the sphincters, and the urine goes into the toilet. So we need a peripheral nervous system that's intact. These sensors have to be working, and we'll find in diabetes and some other diseases that it's the sensors in the bladder muscle itself that stop communicating. And the final thing, of course, you need timely access to a toilet. And this becomes an issue with the cognitively impaired. I don't know why we have this thing that bathroom doors have to be closed. Because a lot of your cognitively impaired people that are up and mobile, if they can see the toilet and they have to go, they'll go to the toilet. And so we actually cause a certain amount of incontinence by not letting them see where is the toilet, even if they know that they could get there. Then there are age-related changes that affect the bladder. So let's talk about those. Urine is made in the kidney, right? Your kidneys are where? Right there. Okay, so the urine is made in the kidneys. There's two ureters come down into the bladder, and the bladder fills. With age, the body does not concentrate urine nearly so well. What would this mean? If your body stopped concentrating urine so well. Pardon? No, it's not. You can get people who get their kidneys shut down, but that's not what I'm talking about here.
Well, whenever you just ask, you can either repeat questions or handle the microphone.
Will do.
And kind of walk on that side, and that way they're not looking at your back the whole time.
Okay.
So we actually have more people online than are in the room.
Okay. 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 So the kidney's not going to concentrate urine. What do you know? When does your urine get very concentrated? When you don't have enough fluid, your urine gets very concentrated. Give me a time when you look in the toilet and the urine is very yellow and very concentrated and smelly. First thing in the morning. How about during hot weather? You know how during hot weather we get these times where a lot of elders will die because they dehydrate quicker? If you can't concentrate your urine, you're going to keep eliminating water from your body. So this is very important. Also, if you're not concentrating your urine, you're going to make more of it, right? So it's going to be a problem when it comes to incontinence. Remember I talked about this muscle? The bladder is a muscle, right? And in order for the bladder to empty, it has to contract down, right? So we get decreased contractility with age. Now I have to use my bag to talk about this. So, well, I'll start with my balloon. happens if you have decreased contractility is you're not going to empty your bladder well. What's that going to mean? You're going to need to go more frequently. Okay, so somebody sits down on the toilet and this is what they do. I'm done. Have you seen that? I'm done. And then what happens?
They want to get up right away.
And then what happens?
Sometimes you don't even get them back to their chair till they have to go again.
Oh! Okay, sit longer and wait for the second pee, because we don't empty our bladder well. And this is the problem with the bedpans, right? All right, let's talk about some techniques that you can use to increase bladder emptying. The older bladder gets what you call some diverticulitis and stuff in it. All right, so now we're going to pretend this is our bladder. All right, and it's got some urine in. Nicole, you want to come over here? Because I got to hold this mic and do this at the same time. Okay, just hold that, just like that. Okay, so I sit down on the toilet and I urinate. Here's my first pee. What do you notice? There's still some there. Now, we're going to do what's called the rock and roll on the toilet to get them to empty out these side pockets. We're going to rock, we're going to roll, and now we're going to pee again. Okay, open it up a little bit so the air can, okay? Another thing you can do, I'm going to show you how you rock and roll. Thank you, Nicole. You can even keep that bag if you'd like. Okay, so I sit on the toilet and I do my first urination. One thing is good position on the toilet. You should not have these little bitty women on these big high toilet with their feet hanging. Okay? Not good position. Feet should be grounded, not only for fall prevention, but also for bladder emptying. What can you use to ground people's feet if their toilet is too high? Step stool. Turn the garbage can on its side. Now, this is a seasoned person here. Okay, so, and especially if you're going to do the rock and roll, you got to have something under their feet. This is the rock and roll. Forward, back, side, side. Now, what am I going to say? Go ahead, try to go again. Oh, I love the tone of voice you use when you say that. This is all about attitude. It's all about tone of voice. It's all about approach. It's all about being person-centered and helping somebody to really empty their bladder. What else helps people empty their bladder? Age-old techniques we use. Water running. What's with the water running? Sounds like a pee. What else is it with water running? Anybody in here have a shy bladder? Some people have a very shy bladder. If Nicole here is very high risk, and I have been told, whatever you do, do not leave her in the bathroom alone. Okay? If I'm standing right here, you're going to be able to poo and peep good? No way. Sometimes running the water is as simple as covering up the noise of urinating. Other things that help people to urinate well are sometimes getting them to blow out their mouth like a straw. Relaxing those muscles. So again, let's go back. How do you know the person that needs this? You just spoke about it. How do you know the person that needs better bladder emptying?
Someone who's mobile.
Someone who's mobile, but how do you know that they're not emptying when they sit down?
Oh, because you don't hear a strong flow of urine.
You don't hear a strong flow, and when you get up off the toilet, you said it a minute ago, what happens?
Yeah, they feel like
You barely get them back to their chair and they have to go again. And this is the negative of using bedpans at night. If I go in and I give you a bedpan at night, and you eliminate, you just take the top off of your bladder, and I leave you, what's going to happen? You're going to have to go again. I'm going to disturb you're going to disturb your sleep again. You're going to wake up again. I'm going to come with the bedpan again, and what's going to happen? You're just going to take the top off again, and you're going to say, oh my God, you know what? She just needs me in there all night long. What's an alternative? What's an alternative? Toilet them. Get them up. Put them on the toilet. Have them completely empty their bladder, and then they can go back to bed. Have you got night lights in your homes? Night lights in your bathrooms? Because sometimes when people talk about waking up too much, it's the bright light that makes them fully wake up. And so if you can have a low ambient lighting, which is very good for the elder's eyes, very much safer, they'll be much more inclined to think they do want to get up at night. What about people who just don't want to get up at night? What do they say to you? Do you have any residents that say, you know what? Yes. There are two different kinds of residents. This is where we get very person-centered. One resident, I have actually seen people weep at the thought of wetting themselves. Absolutely cry. That is just the most awful thing that could happen to a human being, that I'm going to wet myself at night. And then there's people that say, I have such bad arthritis. I really hurt. And once I go to sleep, son of a gun, please don't wake me up. So what do we do for those people? What do we do? Change them when they're incontinent, okay? Pardon? Toilet them before bed, yes.
We use 8 hours brief.
You use a brief that actually will contain them much longer. Okay? Yes. Yeah. Let's talk about double brief. Okay. Double brief. Why is... Why? No, I know you did. And I'm saying thank you for bringing that up. That was an excellent thing to bring up. What's wrong with double briefing? People don't only double brief, they double pad. Some people double pad and they put a pull-up on top of it, don't they? What's wrong with the idea? Oh, thank you. Okay, this has got plastic, right? And this has got plastic. Okay, if I double this up, people will come into my office and they'll say, oh my gosh, every product I try ends up running down my legs when I stand up. I'm like, you're double briefing, aren't you? Because you think you're going to absorb twice as much, and you don't. All it does, and I even have a handy glass of water here. All that happens is that it runs over the sides, okay, and down your legs. So we really, thank you. I mean, I applaud you for bringing up double briefing. Yes, wrongly double briefing. The other thing is we think at night, if we double brief somebody, they'll be drier till morning. But you see, it can't go through. So double briefing does no good at all except waste extremely expensive product. If you are going to put a pad, and this actually is a menstrual pad, which, do any of you let your residents use menstrual pads? Yes. Okay, what's wrong with a menstrual pad? Very wrong. It's softer, but it's not meant to absorb urine. And if you pour urine into a menstrual pad, what will happen is that it's not meant to absorb any fluid that comes out of the body that quickly. And so it just turns into leaky mush. Whereas this is loaded with polymers. And what happens to this when you fill it with water? This is a tonneau pad. Pardon? It kind of gels. It gets heavy and uncomfortable, but it absorbs and it gels and it wicks the moisture away from the body. If you let people use menstrual pads, that moisture sits next to that body and you're going to have skin problems. So a lot of people will try double padding using a menstrual pad. I'm telling you. There's a reason why one is for urine and one is for menstruation. Thank you. I'm very grateful to you for bringing that up. All right, let's move on here. Decreased bladder capacity. If an elder has decreased bladder capacity and that bladder is not expanding so well or holding urine so well, what's that going to mean? Got to go to the bathroom more often. Absolutely. The bladder is very retrainable. Sometimes elders get into this thing of what we call just in case peeing. And we do this, they start this in middle age. In fact, I bet there's a few people here who might be victims of this, of your ride is coming in 20 minutes and you just got yourself all ready and you took your final trip to the bathroom. 15 minutes later, you know what, I'm going to be in the car for an hour and she's usually late to pick me up. I'm just going to go just in case. Now she's 5 minutes late. Oh, well, just let me go to the bathroom and make sure I'm totally empty. That's the way it starts. The bladder muscle is very retrainable, but it learns to be emptied a lot. We do this at night too. I wake up, well, I'm going to go to the bathroom because I don't want to wake up in an hour and have to go to the bathroom. Can anybody resonate with this? I can tell she can a little bit. Yeah, a little bit. Me too. So we have some bad habits. So we've got decreased bladder capacity, makes us go to the bathroom too much. All right, here's a review. You know, if you don't review something 6 times, you don't learn it. Empty the bladder as much as possible when you get there. Be deliberate. Don't have people hurry. Upright position. No bedpans. Techniques for fully emptying the bladder. Stand up, sit down, lean forward, the rock and roll back and forth. Don't strain the pelvic floor. Do not encourage people to push out their urine. It ruins the pelvic floor, which disrupts even further the ability of the urethra to open and close. Decreased warning time. Nicole, can elders hold their urine a long time? No. Decreased warning time. When I gotta go, I gotta go. And we're gonna talk about damping that down a little bit. But they do have problems with holding, and that's a typical time. And this is one of the problems. Carter Catlett Williams says, you haven't lived until you've gone to the bathroom on someone else's schedule. And I don't know how this works in the greenhouses, but traditionally we think people should go to the bathroom when? Every 2 hours. Whether they need to or not, right? Okay. Also, increased bladder spasms. Those are the brain signals that come down to tell the bladder that it should contract. All right. Things that increase our urgency or desire to go to the bathroom that we can eliminate from the diet and see if they're a problem. You know most of these. Coffee and tea, caffeine, alcohol, chocolate, carbonation. Citrus and juice or fresh fruit, cold, fresh, or cooked tomatoes, artificial sweeteners. All right, so if you have somebody with urgency, give me some thoughts on what possible interventions might be. Sarah have to go to the bathroom every hour. By the way, what's normal? What's normal amount of times that an adult has to go to the bathroom? Every 10 minutes? Normal. Normal adult, 4 to 6 hours. 4 to 6 hours. Normal elder, what do you think it is? Normal elder. 2 to, yeah, you're right. Okay, 2 to 3 hours. Normal elder, normal adult, 4 to 6 hours. Some of us do the opposite of the just-in-case peeing. Some people will get up in the morning, they don't go to the bathroom then. They may not even go to the bathroom until noon. This is particularly true of healthcare workers, truck drivers, teachers, people who don't have time to go to the bathroom throughout their day. Now, what happens to our bladders? They get stretched. What happens to a balloon if you blow it up really big lots of times? The air comes out slower because what does it lose? It loses its elasticity. And the same thing is true of people who let their bladders get really big. These people also have trouble with bladder emptying. A bladder, and you said it very well, the urine comes out more slowly. Sometimes you think, oh well, when the if you can't go to the bathroom, if it'll get so big that eventually it'll go, right? Not true. If you want the bladder to regroup its elasticity, sometimes that person needs to be catheterized. You need to get that urine out of there, and you need that bladder to let that bladder recover. So very big bladders that are expanded a lot, in order for that person, this happens a lot in men with prostate problems, they have to go be catheterized, empty it out, may even have to wear a catheter for a while so that the bladder can recover, so that they can then get back to continence because their bladder muscle has now back to its normal elasticity. So what are you going to do if somebody has urgency? Let's go back to this. You want to help them eliminate things. You want to do it one at a time. If George really, really, really likes his morning coffee, let's go back to person-centered care. And then he is just jumping to the bathroom for the next hour. What are the options here? Pardon? Okay, decaf is certainly an option. No, I don't want decaf. Now what's the option? Make it weaker, less caffeine. Okay. What else? Pardon? Yeah, you could try the artificial sweetener to take that away. Less of it? Just like the person that doesn't want to get up at night, would we ever say to somebody, that's your trade-off? So today, if we're going to a special exhibit at the museum, you may say, you know what, today I'm not going to have that coffee because I don't want my bladder to be jumpy. We all do that if we're going to get in the car, if we're going to go someplace, if we know, if we're traveling on a plane. That's not the time when you're going to set your bladder up to be jumpy. So if you know what the offensive substance is, you can eliminate it. Now let's talk about cranberry juice. Is cranberry juice good or bad? Good for what? Okay. Cranberry juice is related to infection. This is the way they think it's related, is that the cranberry juice prevents the bacteria from sticking to the walls of the bladder. So if your problem is infections, you may want cranberry juice. But cranberry juice is an irritant to the bladder. So you see how you start brainstorming these things through? Cranberry juice is an irritant. If my problem is urgency and I have no problem with infections, I want to stay away from cranberry juice. If my problems is frequent infections and not urgency, then I may want to use cranberry juice.
One of our online viewers asked if this has anything to do with urine concentration.
Oh, yes. Yes, yes, yes. Good question. Somebody wants to know if this has anything to do with concentration, and this takes us back to the fluid issue of people cutting down on their fluids because they don't want to go to the bathroom so frequently. Yes? Happens all the time, right? And what happens to the urine? It gets smelly and concentrated. Now, you know elders are not concentrating urine quite as well, so by the time they make their urine smelly and concentrated, what do you think their hydration level is like? In the toilet. Okay. So, all that concentrated urine does a number on the bladder. It irritates the heck out of the bladder. The more I concentrate my urine, the less fluid I drink, the more the sensors in the wall of the bladder are going to get jumpy. They're going to send signals to the brain that you've got to go to the bathroom right now. And the bladder, when you get to the bathroom, will only have about 6 drips in it, right? Okay, because the bladder is irritated. If these people drink more fluid, their bladder capacity will increase, the irritation to the bladder will decrease, their hydration will be better, and all will be well. So, concentrated urine absolutely belongs on this list. And I think now, Mountain Dew is the king of bladder irritants. What's in Mountain Dew big time that just came off that list? Caffeine. What else? Artificial sugar. And what's the third one? Carbonation. So Mountain Dew is called the triple whammy because you've got carbonation, artificial sweetener, and caffeine up the wazoo. So I hope nobody is stalking Mountain Dew. Here's a couple more. Tobacco products. Here's our concentrated urine, and here's constipation. And constipation is a huge bladder irritant because here, okay, so here you've got your balloon, but so they can see. You've got your bladder. Behind your bladder is your colon, right? If your colon is full of hard stool, and then the intestine wraps around the top of the bladder, right? It's going to lean on that bladder. And constipation is going to cause that bladder to be very, very jumpy. So if you have people with urgency, constipation is not going to be their friend. Also, remember we said we need a urethra that opens and closes? Some women who have had a lot of children or have had some surgeries or have had a hysterectomy may have damage to the sphincter that holds the urethra closed. So what's going to happen in this situation is when, in addition to that, they are constipated, that's going to further disrupt the normal alignment of that sphincter. And in women, and we'll talk about this a little bit more in a minute, who have stress incontinence, if they are constipated, they are going to lose a whole lot more urine. Okay. Here again is my slide. Do not let people reduce fluids insofar as you can. People need water for healthy bladder function. So let's talk about these detrusor contractions. The detrusor contractions are, this is the detrusor muscle. The bladder muscle is called the detrusor. The detrusor gets a signal from the brain, down the spine, to the bladder, contract now. Each of these contractions goes like this. Each one, it starts, it peaks. Every single detrusor contraction then will lessen and will go away. So, if you're still sitting here and a while ago you had to go to the bathroom, you might get another detrusor contraction that says, oh boy, I really have to go to the bathroom now. You cross your legs a little bit, and that contraction will go away. So, sometimes what happens to elders is in the middle of a detrusor contraction, they get up and they start running to the bathroom. Yes? Okay, I've got to go right now, and I'm going to get there, right? That makes the contraction worse. So in these people, when do they lose their urine? On the way to the bathroom. Frequently in elders, this kind of incontinence starts when they're coming home from the grocery store and they're getting closer to the door and they put the key in their door and they know they're near the toilet, they get a massive detrusor contraction and it's down their legs. Might be on the way to the bathroom. So we have to talk a little bit about how do you stop a detrusor contraction in an older person. One, don't ever get up and run in the middle of a contraction. But you have to teach this to somebody before. You can't go up and Nicole's having a horrible contraction and I say, okay, honey, just sit there. But the best thing to do is to teach people that we will be able to retrain this bladder. We will be able to do this, okay? But it's best if you're just still during the contraction and then you get up and go to the bathroom. Begin pelvic floor contractions. How do elders do this? For some reason, pressuring the pelvic floor turns off the contraction. So, what some people will do, and these would be people that are getting up themselves at night, is they'll roll up a hand towel and they'll keep it at their bedside. If they get a contraction in the middle of the night, they will push this up against their pelvic floor as they sit on the side of the bed, and that will turn off the contraction. I'm sure you've all known little children who they have to go to the bathroom and they'll put their hand in their crotch and push up. It's the same thing happening. So that's one way of turning off a contraction. Another one is to think positively, count backwards. Think about your grandchildren. So what can we do to control urges? I just told you about the bath towel. People can also use this as they're walking along. They can push a towel up between their legs and push it up against their body. The correct move for turning off a bladder contraction is squeezing like you have to pass gas, and you're not going to let it go. Okay? That's the movement. And when you teach people how to squeeze like that, you got to make sure they're not contracting their thighs, they're not contracting their calves, but rather they're contracting that muscle that would, if you have to have gas very badly and you are holding it back. Let's talk a little bit about hormones, and then we're going to talk about some problems. These are still normal age-related changes. we've talked a little bit about the prostate. The prostate grows with age, and this interferes with the urethra being able to open and close in a man. In a woman, they have reduced estrogen. Now, estrogen not only lines the vagina, but estrogen also lines the urethra. And so with age, as you go through menopause and you lose your estrogen, people have greater problems keeping the urethra closed because the estrogen actually bulks up the tissue. Women will also get what's called atrophic vaginitis, which is something we really don't pay attention to. Shabazz are going to see this because when you're cleaning somebody and you look in between their labia, you'll see that it's red and it looks sore. That's a sign that they simply need a little estrogen cream. Pardon? No, estrogen cream. So it actually has estrogen in it, not barrier cream, because what they need to cure that is a little bit of estrogen, which will actually cure the problem with the urethra as well, and will not only make them more comfortable, but will allow them to be more continent. Squeeze before you sneeze. I'm sorry you can't see the top of that. This is something else we can teach people before you move, before you cough. Squeeze before you sneeze. If you have people that lose their urine when they're bending, when they're moving from sit to stand, if they really want to be continent, squeeze before you sneeze. Again, it's that same feeling of holding back that gas. Also, for women, you can use the analogy of the elevator. So it's a feeling of holding back gas, and then your pelvic floor is going up. And when we do this exercise, one woman started saying, first floor lingerie, second floor hats, third floor. Each squeeze getting harder and harder, and then let it down slowly. So, but you can really have fun and community raising. We have these classes called Total Control, where you're really strengthening your core and your pelvic floor. Pilates is great for improving continence. And you do the pelvic floor exercises, and it's a great thing to get women together to do this. It's a lot of fun. So here's the elevator imagery and the little guy over there holding back gas. We've talked a little bit about nighttime continence. Let's go a little bit further, because one of the changes that is due to aging is that you make a lot more urine at night. Why would that happen? Why would old people make more urine at night? I mean lots more urine at night, especially in the first 3 hours. Okay, well, some of it is how much fluid they have before bed. Oh, yes. Yes. She's saying that as you sit up during the day and your legs swell, that's all fluid. And when you lay down at night, that fluid your heart works better, your kidney works better in that supine position, so all that fluid gets moving, and all that fluid then needs to be eliminated. And the third thing is there's actually a hormone that young people have that prevents them from making more urine at night, and with age that hormone goes away. So it's like there's a lot of reasons people make more urine at night. So what can we do about that if somebody really wants to be continent at night? One thing, restrict fluids after 6 p.m. 2, eliminate caffeine. 3, for your people that get swelling during the day, what can you do to keep that swelling down? Elevate. elevate the feet. What else do we do? Walking, because walking pumps the muscles. Compression stockings work marvelously well to keep the fluid. The other thing is actually putting people in bed with their feet raised above the level of their heart for an hour or two in the afternoon. And there's some thought out now there with water pills that we used to think that, oh my God, you would never give a water pill after 9 o'clock in the morning, right? But now they're starting to think that if you give the water pills about 2 in the afternoon, that when that person goes to bed at night, they are at their lowest water point. And that they may actually sleep a much longer period of time. And some of the most valuable sleep that elders get happens in the first 4 hours at night. So the timing of the medications, we might also be able to use those to reduce the amount of urine production at night. One of the most successful things I have found in my own practice is that if people get up and are toileted about 3 hours after they go to bed, that's when you've got the bulk of that water has been mobilized and is ready to be eliminated. And so if they're willing, and they really, this is what we did with that woman that would just weep about wetting herself at night. And she would go to bed about 9, and we'd say, okay, midnight, we'll get you up. Is that okay? And we'll go to the toilet. We'll make sure you completely empty. And then we won't get you up again until morning. And with that, she could maintain dryness. So the idea is 3 hours afterwards. So we talked about this problem of the bladder contracts when it should not. You don't want people running. People who have gone beyond what's normal into the area of abnormality and incontinence will have frequent, strong, sudden urges to urinate. And these urges will actually result in wetting accidents. Detrusor overactivity is urinating more than 8 times in 24 hours, leaking urine on the way to the bathroom, getting up 2 or more times at night, going to the bathroom so often that it interferes with your life. What's one of the real popular things or cures that you see on TV right now for these folks? You gotta go, you gotta go, you gotta go. And what are we gonna do with you? Take a pill. All right, let's talk about those pills. What's in those pills? They tend to be anticholinergic, okay? They will relieve your bladder spasms. They also will interfere with the action of any dementia medications that you might be on. Because in dementia, we need cholinergic activity. The bladder needs anticholinergic activity. So if somebody is on Aricept and they're on Datrol, the two cancel each other out. If you put somebody with dementia on an anticholinergic medication thinking you're going to cure this problem, you may actually see an increase in symptoms in their dementia. So we have to be very careful using these medications. What I see happening a lot is somebody will go to the doctor or somebody will request that they get put on one of these medications, and nobody ever evaluates whether it's an effective intervention and is giving them relief or not. And they may end up on this medication forever. And as their symptoms of dementia are getting worse, and they shouldn't be on this medication. So this is a problem. We have talked about different interventions that we can use. Retraining the bladder out of this problem is possible with slowly lengthening the amount of time in between bathroom visits, with talking people through the urge to quiet it back down. It is very intense at first when you start working with somebody, but after a while, as that bladder gets more expandable and the urges get more controllable, then you've actually given them more life. Detrusor underactivity. So these are the people, you see the bladder over there in the corner? These are the people whose bladders have gotten so big, or for some reason the bladder's not contracting very well. These will be your diabetics. So if you have someone who is a diabetic, you have to ask yourself, and they're incontinent, and what happens in an incontinent person whose bladder is really big and they're leaking is that they're leaking in spite of the big bladder, just kind of eking through the sphincter, and they really need to get to the bathroom and somehow figure out how we're going to empty that bladder. And does anybody remember what I said we have to do with big boggy bladders? Because this is really important. The person who has a very big bladder and can't empty, be it prostate or be it diabetic, what do we have to do? Catheterize them. We have to get those bladders down. So this really requires an intervention. What you'll see in this person is when they stand, they might have a little leak. When they move, they might have a little leak. Do you guys have bladder scanners? Okay, if you scan this bladder, it's going to be real big. Here's our prostate person. So you can see normally there, you can see the urethra, and in the person with a prostate problem, they cannot get the urine through the urethra. This person will get up, and these are usually your men, they'll get up and they'll stand by the toilet in the morning and they'll try to urinate and they'll get a little bit out. Not very much of a stream, just a few dribbles, and then they leave the toilet, and what do you know? 10 minutes later, they got to go back. They'll stand there again. They have a sense of urgency. These people will leak at night. They'll have be up a lot of times at night. There's also medicines you can take for this problem, which more or less can be of assistance. These are your people with outlet incompetence. These are the people, the women, who no longer are able to close their bladders completely, their urethras completely. So these are the people that look like this. Here's your bladder. It gets some urine in it, and I cough. And I sneeze. These women, if they have very, very bad stress incontinence, probably not going to take them to total dryness. But does this woman need to be toileted? Yes. This woman will not be wet at night. Your person with detrusor that has that urgency, they're going to be wet at night. This person is not going to tend to be wet at night, who has problems with the urethra closing well. It's always just a little open. But these people need to be toileted, so they can be much drier than they are. Now, just a little bit about transient incontinence. And urinary tract infections. Tell me a little bit about what you see with people getting urinary tract infections. Fever. Confusion. Pardon? Delirium. What does delirium look like? They see things. They're out of their normal state. They're agitated. They're moving a lot. And tell me about their urinary tract. Can be smelly. although they have kind of shown that the smell of urine doesn't tell us too much. Tell me something else about their urinary tract. Have to go to the bathroom, have urgency. That's certainly a sign of infection. Pardon? Inflamed, and because it's inflamed, what's the symptom? Burning. All right, so for a urinary tract infection, you need 3 symptoms, at least, right? Okay, and we've come up with a lot of them. Fever, delirium, blood in the urine, urgency, burning, pain. Sometimes nothing, sometimes nothing. And this is, yeah, you're right. Sometimes it seems like they're nothing, and they come up with a urinary tract infection. Well, part of the problem is these people may always have bacteria in their bladder. And we really haven't teased that out. How do we know the difference between a bladder that's always got bacteria in it and somebody gets confused and that's the first label we reach for, urinary tract infection, and it's kind of a blurry area right now. We're all still trying to figure it out, but by and large, we cannot call it a urinary tract infection unless you've got at least 3 symptoms. That's not to say, but the blurry part is we're still not ready to say don't act if you can't find the 3 symptoms. The negative piece is that a lot of times we're not looking for the symptoms. What'll happen is somebody will say, Sarah's confused. She's really confused today. And the first thing we say is, must be urinary tract infection. And we don't go back and say, Sarah, are you having any pain when you urinate? Are you having any burning? And if you really talk to somebody who's there caring for that person, they can tell you from their activity on the toilet what's going on with their urinary tract. If it's different, are they having pain? Are they having discomfort there? Even if they're cognitively impaired. Okay. Stool impaction, we talked about that, and constipation. What do we do about constipation? And what does constipation look like? What are the symptoms of constipation? Difficult, okay, 1, difficult to pass. Hard, dry. Sensation of incomplete emptying. There again, we have to get better at looking at what is constipation, what is urinary tract infection. It can be difficult to pass and the person can have very soft stool. That's not really constipation that we want to treat with a laxative. Restricted mobility, sometimes post-hip, people can have issues with incontinence because of the cutting of the muscles. We talked about excessive urine output. Certainly in depression, you can have people who become incontinent. We talked about atrophic urethritis and vaginitis, and we talked about delirium and infection and that kind of thing. But all of these problems come and go. Let's talk a little bit more about constipation. In our body, I think we all until you really understand the physiology of the body, we think that our food kind of constantly eat, right? Everybody in here had breakfast, and you think that that food just moves along, right? Right? It eventually ends up in the rectum, and we go to the bathroom, right? Okay, the reality is we eat our food, there's lots of water added to it, right? And then it gets into the colon, and the colon moves back and forth, okay? When the food moves along, is exercise or we eat again and we get a gastrocolic reflex and the food moves along. And it goes back and forth again, back and forth again. Okay, another gastrocolic reflex, it moves along. And then we get to the end, moves into the rectum, and boom, we get an urge to go. What if you don't go when you got the urge? If you don't go when you get the urge, BM backs up a little bit and goes back and forth, and the body moves, removes more water, and the stool's getting drier. Comes forward the next time, it's drier, harder to pass, right? Okay. Normally, people have bowel movements at the same time of the day. If we went around the room and I said, okay, what time do you usually have your BM? You don't have to answer me. Valerie, what time do you usually have your BM? We would find a lot of people have their BM about 30 minutes after breakfast in the morning. That's probably the most normal time, and this is why. We go to bed at night and our system is very quiet. The food just kind of goes back and forth and does its thing. When we get up in the morning and we have a drink of warm water, we start moving our bodies, we have some breakfast, boom, time for a good BM. Remember when I talked about the garbage can under the feet for urinating? What's normal move, what's normal position for a BM? Is it this on the toilet? Can you have a BM with your feet dangling? This is a normal position for a BM. Can our elders get in that position? Not easily. So I want to show you what happens. Janet, can you come here 1 second? I promise I won't make you have a BM. I want you to sit on the table.
Oh, you want me to break the table?
No, I don't want you to break the table. If you're uncomfortable, sit. You're not going to make your feet dangle. You want to sit on the table? Doggone it, I'll sit on the table. Okay. All right. So if my feet are dangling and I try to have a BM and move forward, what's going to happen? I'm going to fall. I'm going to fall on what? On my face. This is critical. So I can't lean forward to have my BM. And this sounds very graphic, but this is some of the stuff we have to learn to do if we want people to have normal systems. We can't put them on high toilet seats with their feet dangling and think they're going to be able to have normal bowel movements, which is going to lead them not to be able to urinate properly, which is going to lead them to be compromised and not feel good. So how can they have a life? Right? Okay. So we need to put something under their feet. We need to ground them. Not only are they safer, but they can actually do what's normal for their body. Okay? Normal bowel movement. Knees need to be just a little bit above the level of the hips. You need to be able to move forward. Most times, best time for bowel movements, after breakfast, after lunch, after dinner. That's because of this gastrocolic reflex. Usually at the same time every day. How often is normal? Once a day. For most people. And we always choose to look at the outer edge, don't we? Oh. It's only been 2 days since they had a bowel movement. They're okay. Excuse me, folks, what's normal for this person? If I usually have 2 bowel movements a day and it's been 2 days, you bet it's time. And you're going to see a difference in my urinary continence if I don't have a bowel movement. So we need to have good bowel hygiene. We need to keep people moving. If people are going to take laxatives or anything to help them move, it should be given at night before they go to bed. Okay. What have I not done well here? What hanging questions have you still got? The laxative before going to bed, because what happens is the laxative gets in the body. You've already eaten, so it's not mixing with fresh food. And by the way, this laxative called Colace has not really proved to do, if you look up about Colace, it can be more of a problem than it is a benefit, because what happens is you get a lot of soft, mushy stool in your body that the person cannot push out. Okay, before bed, because the laxative goes into the body is quiet, and the laxative can do its work. And when it works with the body, in that, when that person gets up in the morning, gets moving, has a little bit of hot liquid, has some breakfast, this is the best time for a bowel movement, boom, that laxative is going to work. They are not going to have diarrhea. They are going to have one solid bowel movement, and they're going to be on their way for the day. That's a big nursing thing we need to change. It's really, we've got it in our heads that we don't do that. Other questions? That's a physician's decision, which depends. The question is, if you've got a big boggy bladder because of prostate, or for some women can get retention problems if the bladder is tipped, so that it's not lined straight up with urethra and they can't eliminate. And how long do you want to decompress the bladder? That is very much a physician will make that call. Usually they will start by doing an in and out, just take the urine out and then see if the person can recoup. I've seen some people have it in for 3 weeks. I've seen people 1 week. I've seen some people several months. It's very dependent on the physician. Of course, we don't want catheters left in unless we absolutely have to, because that's a huge portal for infection. Anything else? So, did we answer all our questions that we started with? Let's go back. Is urinary incontinence primarily the result of aging? No, myth. 75% of nursing home residents are incontinent. Yes, it's almost higher than that. It's more like 90. It seems as though you come into a long-term care facility and here's your brief, particularly in rehab facilities. We can't be bothered. Women are affected about twice as much as men. Yes, absolutely. More than 1/2 of continent individuals may experience a decrease in the number of urinary incontinent episodes using behavioral interventions. We talked about lots of them. We can really improve this, which really improves the lives of elders. Nobody likes sitting in a wet product. Are bedpans good? No, absolutely not. Residents on dementia units are good candidates for UI management interventions. Yes, they are. They are some of the best. It may mean leaving the bathroom doors open. One thing that irks me no end is when I see a man that has been put in his trousers backwards so that he can't get to his normal way of urinating when he stands at the toilet. This, to me, is absolute abuse. And we have to be careful of this in putting men in briefs and putting them in anything. Remember, in dementia, what we do is we move with what we've known forever, right? And so a man, when he has to urinate, is naturally going to go in, stand by the toilet, open himself up, and go. And if he runs into layers of brief, Are we promoting continence? Are we promoting well-being? Are we promoting life? So I think we have to be very careful of what products we use on men. Cognitive impairment alone has not been shown to cause urinary incontinence. True or false? True. The chief confounding factor for incontinence appears to be impaired mobility. This is true. This is true. And it backs us right up against what we're doing and how much we need to keep people healthy and well and moving and active, and it's all part of our sense of well-being. Any final questions? Yeah.
I'm curious what your suggestion would be. Someone who knows what they need to do in the bathroom and is continent until you have the moment that lets them not moving. You have a moment to let them say I'm transition almost until you get them there.
Okay, so, all right, so we've got somebody, they know when they need to go, but they have to be put on the toilet by using the lift. And when they're on the lift, they have the incontinent episode. And there's a second thing that's operating there. Remember when I said a lot of incontinence starts when somebody's coming home and they're putting the key in the door? They see the toilet, so they've got the trigger. So that's part of what is going on there. Is there any way you could anticipate this woman's need to go to the toilet? Yeah. And that has to be an agreement between you and the person as well. And the other thing is, in working with dementia, this is all about approach. Suggesting that people are going to go to the toilet, or how we approach them, the words we use, the way we incorporate it into the regular part of a day. Is it ever worth arguing with someone who has dementia about the fact that they need to go to the toilet now? Not worth it. Absolutely not worth it. So in all of this, in moving people towards continence, being person-centered, resonating with what it is that's important to that person. Some people won't want to get up at night. Some people just won't want to go through the struggle of being continent. It's not important. But we can't assume that it's not important for everyone, because to some people it is of incredible importance and they want nothing more than wearing their own underwear. Thank you.